Hello and welcome everyone. Thank you for joining our webinar this morning. It's entitled Lung Screening for Seniors, Should You Be Screened? We're very happy that you've joined us. This event is co-hosted by the Newton-Wellesley Hospital Lung Screening and Nodule Program, together with the Newton-Wellesley Hospital Elder Care Council. My name is Rosanna Morissette. I am the Pulmonary Nodule Navigator for the Lung Cancer Screening Program here at Newton-Wellesley. Our lung screening and nodule programs are a collaboration between radiology, the Department of Radiology, and thoracic surgery. We're part of the Mass General Brigham family, and we work collaboratively with other departments within Newton-Wellesley, as well as other Mass General Brigham sites to improve and standardize our lung cancer screening programs. We have two special speakers joining us who will be presenting on the important topic of lung cancer, lung screening, and support services for cancer care. I want to remind everyone to submit your questions via the Q&A feature, not the chat. The chat will be disabled. When you think of your question, just go ahead and enter it in on the Q&A feature. Our first speaker today will be Sean Lear, physician assistant for thoracic surgery and the lead provider for the Lung Nodule Clinic at Newton-Wellesley Hospital. Following Sean is our second speaker, Christina Terrazzano, nurse navigator for thoracic and head and neck in the Mass General Cancer Center at Newton-Wellesley Hospital. It really is our wish that this time together will be informative, even life-changing. For some of you who may be considering life screening, but you're just not ready to make that commitment yet, we believe this information may be helpful in your decision process. We hope to answer some of your what-if questions. Before the speakers present, I would like to take a few moments to give you some background information on lung cancer screening. So we'll go ahead and get started. Just remember to submit your questions via the Q&A feature. Okay, so let's see. All right, so here we go. Lung cancer screening for seniors. Should you be screened? Again, co-hosted by the Newton-Wellesley Hospital Lung Screening and Nodule Program and the Newton-Wellesley Hospital Elder Care Council. Here are my objectives: to define the eligibility criteria for lung cancer screening, provide you some basic information for qualifying patients to be screened, and a general overview of the insurance coverage guidelines. So what exactly is lung cancer screening? Well, lung screening is more than just a single test. It is a program designed to follow high-risk cigarette smokers and former smokers who meet the eligibility guidelines. A CT scanner, as you can see in this picture, it's like a big open donut. It uses special imaging equipment to create 3D X-ray pictures of your lungs using minimal amount of radiation. The exam itself takes only about 10 or 15 minutes. It's painless, it's non-invasive, it requires no preparation, no fasting, or IV contrast. Screening annually with low-dose CT scans helps to find early-stage disease before a person experiences symptoms, when it's easier to treat and more likely to be cured. Early detection does save lives. Now, I know that this slide is filled with lots of stuff. I'm going to try to get through it quickly. Don't worry if you feel like you've missed something or you can't keep up. this presentation will be available again for you to rewatch. It will be sent in a wrap-up email along with some other links and additional information. So how did lung cancer screening get started? Well, lung cancer screening got started based on the National Cancer Institute launching a randomized trial named the National Lung Screening Trial, or NLST, in 2002. This trial really was the catalyst for lung cancer screening. In addition to that, the arrival of low-dose CT altered the landscape of lung cancer screening, with studies indicating that low-dose CT detects tumors at early stages. This was a game changer. The NLST was conducted to determine whether screening with low-dose CT could reduce mortality from lung cancer. The conclusion: screening with low-dose CT reduces mortality from lung cancer by 20%. That is a significant win. The results, after the trial had ended, the results were publicized by the New England Journal of Medicine in 2011. Next thing that happened that was important to lung cancer screening, the United States Preventive Services Task Force, or the USPSTF, completed their evidence review in 2013. Now, why this is so important is, well, let me first explain that the U.S. Preventative Task Force is an independent volunteer panel of national experts in disease prevention and evidence-based medicine. They recommended that low-dose CT screening as a preventive service for a targeted high-risk population based on a moderate certainty that there is a moderate net benefit with screening, and they assigned it a B rating. Now, why is this grade B rating so important? Well, it's important because under the Affordable Care Act, individual and group plans generally must cover all grade A and grade B rated services without cost sharing to the patient. I want you to keep this in mind, though, that there are group and individual insurance plans which existed at the time of the Affordable Care Act when it was enacted in 2010 that may be exempt from some of the Act's requirements, including the requirement to cover USPSTF grade A and B rated services. So really the take home on this is that everyone, regardless of your eligibility, should contact their individual insurance company and check on their individual coverage to be sure your plan includes screening for lung cancer with low-dose CT. Well, after that, the Centers for Medicare and Medicaid Services issued their own decision memo in 2015 covering lung screening with low-dose CT if all the eligibility requirements are met. Fast forward about 5 years later, lung cancer screening eligibility guidelines were increased. The task force went back and re-reviewed new evidence, which revealed that screening individuals at an even younger age who smoke less can be saved and help people remain healthy longer. The U.S. Preventative Task Force issued an expanded guidelines about March 2021, and the Centers for Medicare and Medicaid Services adopted these expanded guidelines in February 2022. Okay, so in terms of eligibility, who should be screened? The United States Preventative Services Task Force recommends yearly lung screening with low-dose CT for people who smoke now or have quit within the past 15 years and have a 20-pack year or more smoking history, and I will explain in just a moment what that means. And in addition to that, patients must be between the ages of 50 and 80 years old and do not have signs or symptoms of lung cancer. In other words, they must be asymptomatic. Now, this is the USPSTF's recommendation. I want to also stress that Medicare and Medicaid has a different age limit. For people with Medicare and Medicaid insurance coverage, screening does start at age 50, but it ends at age 77 instead of age 80. So, another important point to understand when we're thinking about eligibility is that all of the above criteria must be met in order to qualify for lung cancer screening. It's not a 1 or 2, but all the above criteria must be met to qualify for lung cancer screening. Calculating the smoking pack years is really just a way for cigarettes smoking and the risk factors it brings to help your PCP decide if you qualify for lung cancer screening. Basically, it quantifies your smoking history. So we have to do a little bit of math by taking the number of packs of cigarettes smoked per day times the number of years smoked, and that gives us the pack years. This other screen kind of walks you through it. If you smoke a pack of cigarettes a day times 20 years of smoking, well, then you have a 20-pack year history. Or there are other alternatives to this. If you smoke 2 packs of cigarettes at 15 years of smoking, well, then you'll have a 30-pack year history. Another example, if you smoke, say, a pack and a half of cigarettes a day for 10 years, that only results in a 15-pack year history. That will not mean that you are eligible for lung cancer screening because you haven't met the max limit for smoking history in order to qualify for screening. I think it's important to mention that really needs to be some straight talk about tobacco usage. Now, I know that it may feel uncomfortable to talk about your tobacco use with your doctor or a primary care physician, but really it's important to not underestimate your smoking history. Talking about your tobacco use will really help your provider to plan the right care for you. And just keep in mind that minimizing tobacco use will work against opportunity for enrollment in the lung cancer screening program. So when should screenings be stopped? The USPSTF recommends that annual lung screening should be discontinued once a person turns 81 years old with private insurance or 78 years old for patients with Medicare and Medicaid. It also should be discontinued once a patient has not smoked in 15 years or more, or if a patient develops a health problem that substantially limits life expectancy or the ability or willingness to have curative lung surgery. it's important to keep in mind that unlike the eligibility criteria, where all requirements must be met, only one of the above criteria means screening should stop. So only one of these is required to fall out of eligibility. Kind of to sum up the insurance aspect, most private insurance companies, Blue Cross Blue Shield, Tufts, any of those, the smoking history, you need to have a smoking history of 20 pack years or more, must be between the ages of 50 and 80 years old, and smoke now or have quit within the past 15 years, and be free of signs or symptoms of lung cancer. All of those have to be met in order for this to be covered under most private insurances plans. If you have Medicare or Medicaid services, smoking history of 20 pack years or more is required. You must be between or fall between the ages of 55 and 77 years old. You must be a current smoker or have quit within the past 15 years, and also be free of signs or symptoms of lung cancer, meaning you must be asymptomatic. So really the take-home point I want you to have is that coverage varies. Coverage can vary, and we strongly advise patients to check with their individual insurance company for specific coverage information. Also, prior approval or pre-certification may be required. I want to very quickly share with you some stats from our screening program here at Newton-Wellesley Hospital. So from 2015 to 2022, if you look at the chart on the left, these are the number of screening exams that have been done by year. On the right side of the page, the on the right-hand side of the page, these bars recommend or inform us of the number of scans that have been done for patients in our program by status. So we've had over 1,600 patients enroll in our lung cancer screening program. Some of them were due to come back for short-term follow-up, and then others screened annually. Outcomes of our screening program on the left-hand side shows that we have through the screening program, have detected 86 cases of lung cancer. And the graph shows over the year, by year, how many patients had a finding of lung cancer. On the right side of the page, it shows the lung cancer screening findings by stage. And this really is a good news story that 65% of the total lung cancer cases found in our screening program were diagnosed at stage 0 or stage 1. We're very proud of that. So what are the next steps for eligible patients considering lung cancer screening? Number 1, reach out to your primary care provider or your pulmonologist and request to schedule a visit to discuss lung cancer screening. Shared decision-making, it's a shared decision-making discussion to talk about the risks and benefits and to determine whether lung screening is right for you. This should be done with your primary care provider or your pulmonologist. You'll need a written or electronic radiology order before you can schedule your screening. And then we do advise patients to check with your insurance company for specific coverage information and requirements according to your plan. schedule your screening appointment at an accredited screening facility. And then after your screening is done, reach out to your healthcare provider to discuss the results of the scan. Thank you for allowing us to share this with you today.
Good morning. My name is Sean Lear. I'm a physician assistant who works in thoracic surgery, particularly in our lung nodule clinic, which is a clinic that referrals for both incidentally discovered lung nodules and positive screening studies, as Rosanna has just discussed, can be seen by me and the team here. Let me just share my screen. Okay. So I'm just going to add on to what Rosanna has done a fantastic job of presenting so far. Now you understand how you qualify for lung cancer screening, why it was created, the studies to show that it is important and that it does decrease mortality. So my agenda today is to discuss the rationale behind lung cancer screening, to go over the prevalence of lung cancer, and to explain why it's important to have a lung nodule clinic. So I'd like to start by just talking about the ideal situation for any cancer screening program. Well, we want to identify a cancer that is prevalent. We want to offer the maximum public health benefit and identify those who are at increased risk. For example, for lung cancer screening, we want to identify those who are former or current smokers, although they do have to fit that somewhat narrow qualification, as Rosanna explained. We want a screening test that's reliable, it's safe. We don't think we're going to cause any extra risk to patients. And ideally, this isn't too expensive on our healthcare system. And we want to know that this is scientifically proven to be helpful. So let me start with the first one, cancer that is prevalent. Here's a slide. It's kind of busy because it shows you all cancers, but I thought it was important to show you that this on the left shows you the leading sites of new cancer cases that have presented themselves, or they expect to present themselves in 2023. And underneath are the estimated deaths from those cancers in males and females. So as you can see in males, the most common cancer is prostate, but the most deadly cancer is lung cancer. And for women, it's very similar. Breast cancer is the most common, but the most deadly by a significant amount is lung cancer. And what I think is important to point out here is that if we look at lung cancer and cancer of the bronchus, the airways of the lung, and we look at the age and break it up into males and females again, you can see as you get older, your probability of developing a lung cancer increases quite significantly. So we start screening at the age of 50, but you can see that between 50 and 59, we expect to see 1 in 178 patients with a new lung cancer. By 60 to 69, that jumps to 1 in 59 for men and 1 in 72 for women. That's pretty substantial. And that just goes up as the age is older. But I want to point out the overall from birth to death risk is very high. So for men, it's 1 in 16, and for women, it's 1 in 17. And just to mention here, we are doing a good job of getting the word out about smoking cessation. And overall, there has been a trend towards fewer and fewer people smoking. And that crosses all races and males and females. This is sort of just to sum up what I've said and to make a point that approximately 20% of patients with lung cancer were never smokers. And I think we expect that number is going to rise as smoking cessation continues continues to decline. So these are the same numbers. Approximately, this is for 2022, they estimated that approximately 240,000 people would be diagnosed with lung cancer that year, and that it's the #1 killer of men and women and every ethnic group. If you look at lung cancer in comparison to colon cancer, pancreatic cancer, breast cancer, and prostate cancer, you can see that is by far the leading cause of death, and by many more deaths than the other cancers. So now let's look at lung cancer screening in the light of, is it reliable? Is it something that we can do safely and probably not all that inexpensively? To the patients, yes. To our healthcare system, maybe not. So let's break down lung cancer screenings, the risks, I guess, or the possible side effects. So current screening tests are done with a low-dose CT scan. We do this annually. Unless a scan shows us something and we need to repeat a scan sooner. We've previously tried things like testing your sputum or chest x-rays, and we know that does not work, unfortunately. So what is a low-dose CT? It's about 1/5 of a normal CT. It's the equivalent to 15 x-rays, 50 cross-country flights, or 6 months of natural background radiation. We have a standardized system, which is highly reproducible across institutions across the world. And like I started to mention first above, a positive result usually requires only a follow-up CT scan and not a more invasive procedure. So does scientific evidence support the importance of lung cancer screening and decreasing mortality for patients? So let's just look at lung cancer in general. So here is a patient who presents to our clinic and has one area of cancer localized just to the lung. And on the right here, on the CT scan, you can see it's that white kind of solid area at the very top of the lungs on the right side of the screen. So if we catch a cancer in stage 1, most often, if patients are healthy enough, it's treated with surgery. If not, then radiation is a great second best offer. And if that's the case, the 5-year survival for those patients is 70 to upwards of 90%. Now, what if the cancer spreads to one lymph node? How does that change things? Well, that makes it a stage 3A, and it decreases the 5-year survival down to only 33%, quite significant. And how about if it's found somewhere else in the body? It's metastatic. It's spread to the brain. It's spread to the adrenal glands. Well, then the 5-year survival at that point is less than 10%, and the option of surgery is not available. We just try to treat these patients and make them comfortable with chemotherapy, some targeted therapies that target specific mutations that these cancers have, and immunotherapy, which boosts the body's ability to fight off cancer. So it's important, right, that we find this at an early stage. The challenge with this is that early stage lung cancer does not show any symptoms. People are, if they do have slight symptoms, they're usually easily confused for something like a pneumonia, a COPD exacerbation, a viral infection, COVID. But when we do see patients who have who are symptomatic, we know at that point the disease has spread, and likely it has spread and is a stage 4. So those signs and symptoms are what we hear about, right? Chest pain, usually it's a localized pain, like this is exactly where it hurts, right here. Feeling short of breath, hemoptysis, that means coughing up blood, and large lymph nodes that you might feel up here by your clavicles. Weight loss, fatigue, these are all signs of advanced disease. And when we see this in patients, then it's very discouraging because our options for treatment are nil. So preclinical detection is key, and most 60 to 70% of patients with lung cancer, do present with advanced disease. How can we stop that, right? So does lung cancer screening work, and what's the evidence? Yes, it does work. Rosanna kind of went over some of these studies, but there are two large randomized controlled trials that proved that screening with a low-dose CT scan does decrease mortality in those patients. It is a high-risk population that's identified. And then the National Lung Screening Trial, it decreased mortality by 20%. And in the Nelson trial, it decreased it by 24%. That's fairly significant. So how well do we do with lung cancer screening? How good are we at saving lives? Well, if we look at these numbers, these are the number of patients needed to screen to save one life. So in order to save one life from colon cancer, you have to screen 5,000 patients. In order to save a life from breast cancer, you have to screen 1,300 patients. Well, you only have to screen 303 patients to save one life from lung cancer. This part is fun for me because I like to see what people would think. And I know this isn't an interactive presentation, but just in your minds, think like, well, how many people do you think in the US participate in these various screening programs? So how many do you think participate in breast cancer screening? The answer is about 70%, which is great. What about for colon cancer? About the same, 60%. What do you think for lung cancer? 5 to 6% of people who are eligible to participate actually participate. We do a slightly better job here in Massachusetts. Our number is closer to 16%, but that means that we are then missing 84% of the population who qualifies. And we know this is life-saving. So why have a lung nodule clinic? I would like to give a little shout out to our Chief of Thoracic Surgery, Dr. Henning Geisert. He is the father of the program here. He started it, he advocated for it, and he is always championing this program. So when we have lung cancer screening programs, do people get treated sooner? Yes, they do. So if we look at lung cancer screening patients versus routine patients who may be found a suspicious nodule incidentally on, say, an abdominal CT scan that catches the bottom of the lungs, or more popular recently, we have cardiac calcium CTs, and those sometimes identify incidental nodules. So let's look at the lung cancer screening patients. By the time they're imaged and they have a suspicious image, their time to a clinic visit is significantly faster. It's more streamlined. The number of trips to the hospital for workups, visits is more like 2 visits versus 4 for a routine follow-up for somebody with an incidental nodule. And because we are so streamlined and we know we're specialists in this area and we know what tests need to be ordered, we decrease the cost because we're only ordering what's actually necessary. So the total time from a suspicious lesion to treatment for those in the lung cancer screening program is 40 days. Oops. And those with incidental nodules, it's more like 68 days. So it makes a difference when we're talking about cancer. So what does it look like when you refer someone to a lung nodule clinic? So typically it's a clinician who refers the patient, primary care physician, or it could be a clinician that sees somebody in the hospital through the emergency room, sometimes cardiologists who are looking at those cardiac calcium studies. So the referring clinician refers to the clinical strategist, which would be me, the physician assistant, with any abnormal imaging findings. And at that point, I will review the images, triage to whichever clinical person is appropriate, whether it be the surgeon or medical oncologist. We also, you can see support services here. We do have Dr. Bullis is a wonderful resource for us. He works at the Vernon Cancer Center and offers smoking cessation therapy, treatment, help. Next, we want to get quickly to a diagnosis and further testing so that we can get to a diagnosis. And then come up with a treatment plan. I think what's important here to mention is that we don't do this alone. You know, it's not just me behind the screen looking at the images and coming up with a plan. We do this with an inclusive team of specialists. We get the input of radiologists, interventional radiologists, pulmonologists, radiation therapists, thoracic surgeons, oncologists. So it's a big team that weighs in and gives their advice. We have a thoracic oncology conference that we present, where we present patients who have either anyone can present out of that group, and it could be someone who is just challenging, like what's the next step with a lung nodule finding, or we always review lung RADS 3 and lung RADS 4 patients again to see if the recommendation is correct. So we get sort of a second opinion from a radiologist reading these studies again. And then, you know, we are there to ensure that treatment is complete, where a personalized care team is provided. We have phenomenal administrators here in our department, Debbie Sankrika and Suzanne Heffernan, who are quick to get back to patients, get them scheduled for their appropriate tests, make sure that they are available and make it to those appointments, and get them back in here for us to discuss next steps. So Rosanna kind of went over some of the data too, and I'm going to look at this a little bit differently. So this is looking at patients who came into the lung nodule clinic, and that is lung cancer screening patients, but it also includes patients who had an incidental lung nodule found. And I'm also going to, our program started, the lung nodule clinic was opened in November of 2019. And so I'm going to look at the data from the beginning through December of 2022. So her data shows she's got a little higher numbers, but that's because I'm looking at this slightly differently. Shows the same trend, which is fantastic, right? So from 2020 to 2022, we were able to, despite COVID, find an increasing amount of patients with lung cancer. And that's great, but what stage are we finding them in? Well, we're doing a really good job of finding them in an early stage. And just to reiterate, stage 1 lung cancers are curable. They're curable with surgery. If a patient isn't healthy enough, they're curable with radiation therapy. So I just want to go over our goals and our commitment to you and to the providers in the community. We want to be a place where we can achieve complete follow-up on any lung nodule that meets the risk criteria for malignancy. We want to facilitate an easy single contact person for scheduling, improve the utilization of radiographic follow-up studies, order what's appropriate, appropriately utilize invasive diagnostic interventions such as CT guided needle biopsies and bronchoscopies, where we go in and try to get a tissue sample. And we want to utilize a multidisciplinary approach, which we are. So I think right now we're doing well with our goals. We are committed to this Newton-Wellesley Hospital community, and we want to figure out how we can reach more people. So if you have any questions, my phone number is here. I do not mind a direct call to my office. I do not mind a direct email either. So we will provide this information again with a follow-up email after this presentation. But I just wanted to make that available to you there. So next, I'd like to open the stage for our next speaker, which is Christina Terrazzano. She is our oncology nurse navigator who specializes in our lung cancer patients, among others, at the Vernon Cancer Center. I also want to remind you to please submit any questions to our Q&A feature and not to the, let's see, and not to the chat. And next up is Christina. Thank you. I really appreciate your time and your interest.
Hello, everybody. Thank you for coming today. I am Christina Tarazano. I am the thoracic and head and neck nurse navigator at the Newton-Wellesley Hospital Cancer Center, also known as the Verdin Cancer Center. I'm here just to go over the nurse navigator role, the referral process, which would be self-referrals in some cases with some insurances, as well as internal referrals, so from the lung nodule clinic and some other providers such as PCP offices, and self-referrals and outside referrals. I'd also like to just go over the supportive services that we offer, which Sean graciously did mention Dave Bullis, who also works with our department as well. And I also would like to discuss the ways in which oncology patient navigators may assist patients, but also the caregivers. Just so to clarify, I am somebody who gets involved in when the patients are referred to us to see a medical oncologist. So there's concern for, a lung cancer. So that's when I would become involved in your care. So the definition of an oncology nurse navigator. So it is a professional registered nurse with an oncology specific clinical knowledge who offers individual assistance to patients, families, and caregivers to help overcome healthcare system barriers. We use the nursing process, and Navigator provides education and resources to facilitate informed decision-making and timely access to quality health and psychosocial care throughout all phases of the cancer continuum. So it's not, I don't just get involved at the initial visit, which I do like to introduce myself then, but I am there for you as a point person throughout your whole care while you are being seen by our department. We also connect with patients in the early and after diagnoses. So when you get referred to us, I'm the person who calls you and sets up the new patient visits with our provider. We also assess and address barriers to care, such as, caregiver concerns, but also maybe patient concerns such as transportation, insurance concerns. So we help, with the financial point as well. And other concerns too, such as the smoking cessation, in which we do have Dave Bullis, who's great with that. He is part of the psychology team, but I like to refer to him as our counselor because, he does counsel all of our patients. He sees all of our cancer patients, not just the lung cancer patients. He's very knowledgeable. I also am the person who puts in referrals and makes connections for you for resources and support. So I also do the referrals, like I had mentioned, social work, Dave, psych, massage, Reiki therapy. The first one's free. So it's all great stuff in which we try and help to get patients involved early on so that if the need is there later on, then it's already been established. I attend the initial consult, so I'm usually there during the first visit, which is also I cannot be there as well. If you would like me to step out, I can do that as well. I just like to be there to kind of get a sense of what the plan is for you while you receive care, just so that I can provide my best, knowledge and support while you're going through the treatment. I also am, like I had mentioned, the consistent point person across the entire continuum of care. And so I do provide you my card with the direct contact. I have a direct line, which you can leave voicemails at, and I'm there every day of the week, which is nice as well. So I'm available, I like to say 24/7, but it's obviously only 8 hours out of the day, but I'm available every day. And so to kind of go about how we see patients, so initially, I like to, when we receive referrals, whether it be through the Nodule clinic, through PCP office, or some other internal referrals or external referrals, I like to assess to see what type of providers need to be involved at that initial visit. We like to really get our patients seen in a multi-visit, is what we like to call it, in which our the initial visit is an hour long, and you see a medical oncologist, a surgeon, so a thoracic surgeon, and a radiation oncologist if needed. I like to kind of assess and what's needed initially, so that way we can cluster care. Cluster care is great for our patients, and it allows for one visit to see all the providers on one day, instead of having to come back and see multiple providers on different days. It also helps get the process started on your care and getting you started with whatever treatments needed right away. And then we also like to, so when I call you to schedule that visit, I like to just clarify with the patient the difference between each. So what a medical oncologist is, so to clarify for all of you, a medical oncologist is the point person in your care who would be giving you chemotherapy treatment if needed, or who would be whether it's through an IV and you come for treatments every so often, or it be a oral medication that can be targeted treatments, depending on mutations. As Sean had mentioned earlier, we also, to get those mutations, we do testing for that. And so all that testing is consensual, and we like to get that either prior or during the first initial visit to see if something can be given orally, in which that sometimes usually lasts longer for treatment beyond the chemo if it's needed. And so I like to clarify what the difference of a medical oncologist is between a surgeon, which the surgeon, as many of you may know, listening to Sean, is who would do the surgery to remove the possible cancer if it's able to be removed. And then a radiation oncologist works with our team as well, in which radiation may need to be given along with chemotherapy. If not, then, they don't get involved at all. But if it's needed, it can be given either prior to the chemo start, during chemotherapy, or if something is needed to be given after. And all these things may or may not happen after getting surgery for something that's concerning in the lungs. Such, just it could be a nodule that needs to be removed, and that's it. And maybe you don't need to come see us. But if you do, then we like to, as I had mentioned, get you started with all these type of providers if needed. And so I also feel as though I want to make my patients very comfortable with coming to me with some questions that maybe they're not very comfortable talking to the physician about, just because they don't know how to approach the question or ask the question properly. And so I like to hopefully make my patients feel as very comfortable as they can, and turning to me for some things that maybe I can ask the provider for them. And so that's also my goal when providing and helping you with your care. Next, I'd like to talk about our integrative supportive service program, which I had mentioned briefly with the social work, palliative care, psychology. We also have Lyft, which is a ride service, which many of you may know about Uber and Lyft on the outside world. And so we actually have something for our patients in which an account is set up, and we provide Lyft rides just to and from appointments, because a lot of patients who may not be able to drive need to get to their appointments, and we want to try to eliminate that stressor for our patients. And so the Lyft program is great, and you don't have to be computer savvy for it. We are able to actually book them for you, the rides, and to and from your home. But you also are able to do it yourself if you are computer savvy. We also have the palliative care, which is not necessarily depending on what stage of cancer you have, but they are also great in helping Dave Bullis, our psychologist, because if you need medications for symptom management, simply just that, or for medications he may recommend for anxiety, or even if it's like you have some anxiety for like scans or something like that, then palliative care actually prescribes it. Dave cannot. So we do palliative care usually initially for some patients, depending on their situation. Social work is great also. We like to have them involved initially just to assess the patient's needs. They do really great in getting in-depth information from patients and touching base with them one-on-one on what needs might be while they go through this treatment. And so they are great in getting involved initially for our patients. Next, we have massage and Reiki. Those, like I had mentioned, the first one is free, but after that, they do end up charging for the massage part. Some of it does not go through insurances, but it's always great to kind of get that base and call your insurance company initially if you plan to do that, to find out what kind of copay you may have. And we also have a lot of programs in our cancer center for all of our patients for funding purposes. So for copay assistance if it's needed for your visits, because maybe your insurance requires a copay every time you come. And as I had mentioned, the transportation for Lyft and medications as well. If there's medications that have to go through specialty pharmacy and not through a regular pharmacy like CVS or Walgreens, but those medications that have to go through specialty pharmacy tend to cost more, or may need to be assessed for a need for funding through our department, and that's also an option for our patients, and we're able to do that as well. Next, I'd like to go over the distress thermometer. So me and one of my other colleagues who works with the GYN and GU patients, which is the gynecology and the GU system as well, we are piloting this distress thermometer. So what I have been doing, what this is that it assesses patient stressors and anxieties at the initial visit. So when I come to meet you, as of right now, what I've been doing is telling the patient about the distress thermometer, giving them a brief summary of what it is. The point of it is to assess our patient's needs and stressors that they may be experiencing at that initial visit, and the concerns they might have now that they have this cancer diagnosis, and I have all these other anxieties in my life, and I just need help with other things as well. And so the goal of this is to kind of assess those stressors and get you started initially with our integrative services program. So it's based on a scale of 1 to 10. There's also a checklist of symptoms, stressors, and concerns in which you, as the patient, would fill out. Based on your score on a scale of 1 to 10, if you receive above a 5 or above, we like to, call you with that score and discuss with you some supportive services that we are recommending initially. So I would call you and say, based on your score of a 5 or above, I think it would be great if we could get you involved with social work and with Dave initially, just to kind of assess your needs and what might those stressors and anxieties be, and what we can do to help you. And so that's what we are piloting and hoping to integrate into our role as a nurse navigator for our patients. The providers are made aware of your distress thermometer scores, and they are made aware about the referrals that are being placed and what's recommended. And so that's something that we are able to also scan into your charts just to kind of look back at in case it's needed. And to kind of specifically go over what this checklist of stressors and concerns may be, they touch upon practical concerns such as work, school, and finances, spiritual concerns such as faith, beliefs, rituals, and dietary needs, social concerns such as relationships and communication, as well as physical concerns such as sleep, fatigue, sexual health, and changes in eating. And so based on that, we also have nutrition, in which we get patients involved as well if they've already have started losing a significant amount of weight and need help managing that, or managing what type of nutrition to eat while going through treatments. And so that's also another supportive service that's great that we utilize a lot. And so after these stressors are assessed and we get these results, as I had mentioned, we follow up typically the next day, just so that the patient can digest, everything from the appointment. And if there's questions that evolve overnight, then I'm following up the next day and hopefully can answer those questions to my best ability. And if not, I do bring those other questions that I'm not able to answer to the providers, and are able to be that person, like I had mentioned, the point person, in which is able to go back to you after talking to the provider with those answers. And so these referrals that are recommended, you do not have to comply to them. You can decline, and we can always push them off. And so otherwise, we do like to put as many referrals in initially just to establish care with the patient. And then if it's not needed initially, then at least we've established care. And then that way afterwards, we can always go back to it. And it's much quicker to treat the patient if we establish the care earlier on. And so that's what our goals are with this distress thermometer. And so far it's been working out very well. We have had much outcomes that have turned, patients into with services we've turned around much quicker. And so they're able to get their needs met much sooner than later on. And that is all I have for you all today. Again, thank you so much. And if you have questions, the Q&A again is available there. We're going to try and answer all those questions to our best ability today. And thank you all again.
Thank you, Christina, and thank you, Sean. What wonderful presentations, loads of information. We are ready to step into the next section of our event today, and that is the Q&A section. Christina, would you be able to just close that down for me? That would be great. There we go.
So I'm happy to jump in and answer the first question. This is from
Awesome.
a patient, from somebody who's viewing this. Who said, I'm 82, heavy smoker for 45 years, quit in 2000. Screened for several years, which is great, but then now he no longer qualifies based on age, and it's been more than 15 years since he quit. So let's see. Did have COVID and did long COVID. Should I be screened now? This is always the tough question, right? We know that your risk still exists. You wouldn't qualify for screening, so it would not be a screening study. Could you get a CT scan? Just a regular one? That's a conversation to have with your primary care physician. Having symptoms of long COVID might qualify you to go see a pulmonologist as well. And they are also, experts at determining risks and, determining what studies need to be ordered. So it's a bit frustrating for us, as it is for you, that we know that the risk does not go to zero. And unfortunately, we don't have coverage by insurance to continue to screen.
Thank you, Sean, for answering that question. I do want to point out one thing that I just happened to notice regarding the coverage for Medicare and Medicaid. On my slide, I had posted that you needed to have a smoking history of 20 pack years or more and be between the ages of 55 and 77 years old. I want to make that correction for patients with Medicare and Medicaid coverage. The age criteria is between 50 and 77 years of age. We'll make sure that we update those slides when we send them in the wrap up. So thank you to Lee Nealon for pointing that out to us.
I'd like to just address one topic that seems to come up by a few of you. You were never smokers. We know that you are still at risk for getting cancer because, as the statistics showed, 20% of patients with lung cancer were never smokers. So our hope is that we will find a test that is, less, that costs less. It could be something like a sputum test. I know they've been looking a little bit into a breath test too, but I think that needs to be correlated with a CT. So people are working on it. I think as we see the decline in smoking, as we have already, and we're not seeing necessarily the decline in lung cancer, we're going to have to address that. But right now, we unfortunately cannot. That's why when nodules are found incidentally, most of those are not cancer. But when we do find it and they are cancer and it's incidental, it's, you know, it's gratifying, it's rewarding, but it also is like, oh, if they hadn't had that study, it would have been missed. So we still have a long ways to go. You know, this is a pretty new program. I think that addresses that. You know, I know there's people who've been exposed to pollution or secondhand smoke. We know those things put you at risk. But right now it doesn't fit the criteria for qualifying for lung cancer, unfortunately.
I just also would like to mention, just to go off of that I see a question about, I have a friend who never smoked and got lung cancer. As Sean had mentioned, although we know risk factors such as the pollutants and secondhand smoke, you know, are factors, they're just not purposes for the lung screening, cancer screening as criteria. You know yourself. And so if you have symptoms of something that are new or unusual, such as, you know, coughing up blood, or you have this new cough that you've never had before, if you feel that something is different or has changed, there's no harm in you going to your PCP office and bringing these concerns to them, because they can always order whatever they feel is needed to possibly come to what's the cause. So, you know, like I said, you know, we as providers are, you know, great at assessing patients and diagnosing patients, but at the end of the day, you know yourself best, and you should definitely, you know, look out for things that are different or unusual for yourself and bring them to your PCP's attention.
And I just want to remind everyone that there will be a wrap-up email sent out to all participants in today's webinar. So if something was not addressed, we'll be sure that you'll have all the information to answer that, and we'll have our contact information in there. Should you like to send us any requests to answer questions, we'll be happy to get back to you. Just because we are running short on time and we may not be able to get to all of these questions, I want to assure you that in your wrap-up email, there'll be a lot of information that will hopefully address those questions. But if not, you can feel free to reach out to us. Contact information will be there, and we'll get back to you as soon as we possibly can. I also want to take a quick moment to shout out to Kim Gerard for organizing this webinar for us today. She really helps pull this all together. And also I want to thank everybody who did attend today's event. We are really appreciative for the opportunity to spend this time with you. It's our pleasure. We'd like to help raise awareness of lung cancer in our community. I'm sorry we didn't get the chance to address all these questions, but we'll be sure to include information in the wrap-up email to get your question answered.
I'd like to take a quick moment to address
Sure.
one comment I see in there.
Yep.
Because I think it's important to address. This person, rightly so, feels upset that at the age of 80, it seems like we feel like they're past an age of treatment, right? Because our cutoff is at 80. And I know you've experienced this this person has experienced this in other, with other providers. I want to let you guys know that our thoracic surgeons and our oncologists and radiation oncologists treat people well into their 90s. So we don't say you're 80, you're too old. You know, we know people are living up to their late 90s. It's just that the screening stops at that point. But I want you to know we don't. We still advocate for you, and we give you the options of treatment that we give someone who is 50 or 60.
And just know, for those of you that are asking about the eligibility, we'll be sure to include all this information in the wrap-up email, as well as this whole presentation will be posted online for you to view at your convenience. So you can go back and review any part of it. We'll make sure that you have all that information. We're sorry we didn't get to all of the questions today.
Thank you, everyone. Really appreciate
Thank
your time
you so
here.
much. We enjoy this opportunity. Thank you.